Today we will discuss the topic of seizures and its differentials. In seizures, there is an abnormal synchronized firing of neurons in the brain. It's just like a shortcut in the brain, and the differential between seizures and syncope is important. There are many types of syncope, but here in this table, you have it's a differential between vasovagal syncope, a specific type of syncope that occur when a patient stands very long hours, standing very long hours, and also experiencing some physical or emotional stress. In vasovagal syncope, patient experiencing prodromal symptoms like he will feel lightheadedness, he will undergo in some aphoresis, he will sweat a lot. And also, it mostly occurred during a standing condition, like a patient in CK. The examiner will describe a patient about standing in some situation, like in some playground watching a sport, and high on emotions, like he will be cheering, or some kind of strong emotions. In seers, there are basically a preceding aura instead of prodromal symptoms. Aura means a focal neurologic deficit. Reversible focal neurologic dysfunction is called aura. In seers, patient will have some type of hallucination. It may be visual, auditory, or olfactory hallucination. Seer can occur at any stage, at any position, like it can occur with sleeping, sitting, but in vasovagal syncope, it is unlikely to occur while sleeping or sitting. So the characteristic symptoms or signs of seizures are tongue biting. After patient will bite his own tongue when he is seizing, and will undergo and will experience incontinence. But in vasovagal syncope, there is a weak, slow pulses, and patient will have pallor and diaphoresis. It's due to some pathological condition. Physio is very simple to understand for syncope. It's due to excessive sympathetic system activation or parasympathetic activation. It's just like imbalance between sympathetic or parasympathetic. Like a patient will undergo diaphoresis, pallor due to peripheral vasodilation, and reflex tachycardia. So in seer, patient will have rapid, strong pulses, but in vasovagal syncope, patient will have weak, slow pulses. In vasovagal syncope, it's uncommon to have clonic jerks. Like patient will stiff and then will relax. In generalized tonic clonic seers, there's two type of situations. First, patient will undergo stiffening of the muscles, then will undergo relaxation of the muscles. And the most important differential between syncope and seer is the immediate return to baseline in case of syncope, but in seers, patient will experience some post-ictal or post-seer confusion. This point is very important. You can differentiate between syncope based on this point, and tongue biting, incontinence, and this point. These 2 points are very important. There are many triggers of seizures. It's not important to actually remember or clamp all these points. You have to just read one time these seizures, triggers. Like there is a lack of sleep in case of seizures, or flashing light, emotional stress, alcohol withdrawal, or maybe idiopathic. We don't know. So here is the question scenario of a seer. 17-year-old girl is brought to the emergency department by her mother after an episode of loss of consciousness 20 minutes ago. There's a loss of consciousness. It can be seer or syncope, and we will differentiate based on the previous table. The patient was taking a shower when her mother heard her fall. By the time the mother opened the bathroom, she was lying on the floor and unresponsive. Okay. The other important point was patient was drowsy and confused. This point is very important because it's due to post-equal confusion, and it's a important differential point between syncope or seizure and seizure. Under significant stress, okay, it's a trigger point here and has been sleeping poorly. So there are two trigger factor for seizure. Her vitals are normal. Patient is now alert and answers questions appropriately. Examination of the head shows no obvious injuries, tap off or hematoma. Okay. Finger stick glucose level is 100. The examiner mentioned this point because hypoglycemia is a cause of seizure. Which of the following is most likely to be seen? So it's tongue laceration is the important point. In seizure, there is a tongue laceration, but in syncope, there is not a tongue laceration. Here is some explanation. The patient experiences sudden loss of consciousness associated with the loss of postural tone. Okay, it's a post-ictal confusion, generalized tonic-clonic seizure. Okay, tonic-clonic movements typically last less than 3 minutes, maybe unwitnessed. So it's also an important point, and I will explain to you in next slides why it is important. Because in generalized tonic-clonic seizure, it's mostly unwitnessed, and patient will experience some focal neurologic dysfunction like olfactory hallucinations, biting injuries, tongue laceration are common during the convulsion. Lycians almost always have a delayed return to baseline neurologic functioning due to the post-ictal state of transient confusion. So post-ictal confusion is transient and it's not present in syncope. Okay, the answer is syncope. Orthostatic hypotension. It occurs in syncope. It occurs in syncope due to peripheral vasodilation. And for that moment, you can say it can happen, uh, and the remaining differentials are not so important. Just need to remember the differentials between vasovagal syncope and CS so that you can point out the exact option. Here is a differential between CS and two types of syncope. Now it is cardiogenic syncope. In cardiogenic syncope, the patient will have some cardiac issues, like he will have some cardiomyopathy, left ventricular hypertrophy, or another type of cardiac issues. The main differential here is immediate return to baseline. So you can easily differentiate between seizure and syncope based on post-ictal state. Post-seizure state is the important state to differentiate between these difference between seizures and syncope. In cardiogenic syncope, it's a sudden loss of consciousness without prodrome. So in vasovagal syncope, there is a prodrome of lightheadedness, pallor, or diaphoresis. That differentiate between cardiogenic and vasovagal syncope, this point is very important. We have covered these 2 points in previous table. So here in this scenario, you can see an 8-year-old boy brought to the emergency department 45 minutes after falling out of bed. He asleep for about 10 minutes when his mother heard a thud and immediately ran to his room. The patient was unconscious on the floor with blue discoloration around his lips that resolves after a few seconds. Okay, the patient regained consciousness after a few minutes but seemed excessively sleepy. So the patient was sleepy due to the post-ictal confusion. So that's the important point to differentiate between syncope and confusion. The patient was drowsy but responsive on the drive to the hospital and was able to talk in an unassisted. The patient is now alert. The post-ictal confusion is transient. After some minutes, the patient was alert and interactive, but does not remember anything about the event. It's an easy question. They are talking about some diagnosis. So here it's not cardiogenic syncope because most of the time cardiogenic syncope occurs in older age group due to cardiomyopathy. Also, you don't have post-ictal confusion in syncope. Hypnagogic hallucination cannot be right because it occurs in narcolepsy. And for narcolepsy, patient will undergo cataplexy, which is a sudden loss of muscle tone due to some strong emotion. So it's not syncope based on post-ictal confusion. This is not right. This is not right. Breath holding spell. Breath holding spell. The patient returns immediate to baseline. So that's a very important point to differentiate, and you just need to know that these 2 points: immediate return to baseline and tongue biting. Differentiate between vasovagal syncope and cardiogenic syncope. You know the difference between uh, the aura, pre-syncope or prodromal symptoms. In cardiogenic syncope, the patient will not experience any prodromal symptoms. It's sudden and during exertion. It will be sudden and during exertion. So here's a first time seizure in adults. Whenever an adult presents with the first time seizure, we will undergo some evaluation, and that evaluation is very important. For example, the patient can undergo. We will I will describe to you the etiology of first time seizures in a very brief, because these points are not so important. But to remember these points, you need to have some idea of what is the causes of what are the causes of seizures in adults. For example, patient can undergo seizure during hypoglycemia or some electrolyte disorders. It can be due to substance use, withdrawal, medications, or can be due to acute brain injury due to hemorrhage or meningitis or encephalitis, or due to some stroke. The patient have some tumor in the brain, which is causing short circuits in the brain. For temporal sclerosis, idiopathic, it may be due to unknown causes. So, whenever an adult presents with the first time seizure, we will undergo laboratory investigations, so that we can rule out the causes, most common causes, and can find the appropriate cause and will treat according to the cause of the CS. Like if it's due to some tumor, we will go for surgery to remove that tumor, so that patient can have a good life. So we will test for glucose to detect for hypoglycemia, for CBC, and we will go for electrolytes like hyponatremia will cause seizures, and we will also go for other baseline metabolic panel, right? RFTs, LFTs, and urine drug screen to screen patient for substance use or withdrawal. For detect structural lesions in the brain, we will go for CT scan to detect any hemorrhage, or MRI for smaller lesions and tumor. Tumor is more detectable on an MRI. And we will go for lumbar puncture. Patients presented with fever, knuckle rigidity, like in the case of meningitis and encephalitis, and also EEG. These are the investigations which you need to remember if a patient presents in emergency or in OPD for first time seizures. So here it's a explanation of this table. So I think we have already covered this table, and that's the important, you need to remember this table. Okay. And there is another scenario of this table, related to this table. So a young woman presented to emergency department after a seizure episode. The seizure occurred at work and was not preceded by any prodromal symptoms or aura. So it's due to not any prodromal symptoms, so it's rule out syncope. And aura can happen with the seizures or not. So it's not a specific. The patient's coworker reported that she became unresponsive with generalized tonic movements, lasting 1 to 2 minutes, following by several minutes of confusion. So here is a post-ictal confusion. It's a specific indication for a seizure. She experienced urinary incontinence but no tongue biting. So there is no tongue biting, but she has urinary incontinence, and that's also specific. For years, the patient has no medical problems, takes no prescription medication, she has no prior head trauma, no family history of epilepsy. So, non-contrast head CT is normal. Which of the following is the most appropriate next step in the management? Check urine drug screen. Like in the previous slide we have already covered that we should check urine drug screen to detect substance use or withdrawal. MRI of the brain with seizure protocol. Reassure patient and discharge home. No, it's a first time seizure. We will go for comprehensive metabolic panel, blood glucose, serum electrolytes, and all these causes which we have already talked about. Routine EEG, start valproic acid. No, we will first diagnose and we will do investigations, then we will treat. So it can be easily ruled out. Routine EEG. First, we will go for investigations which are easy to perform and most common. So that's why it's not routine EEG. First, we will go for metabolic urine in the case of this we can, because it's a young woman. She's a young woman, and in that age group, substance abuse is very common. So we will go for urine drug screen before we will go for MRI or routine EEG. So in this case, it's a metabolic that's important. But in another scenario, which we were talking about on Messenger, we will go for MRI due to the presence of meds, due to the suspicions of malignancy, and due to the patient age group. In this, that's also important to see if you are confused between two or three options. Like in this scenario, this can be easily ruled out, so it's easy to rule out, and reassure patients, so it's also easy to rule out. Now these are three investigations which can be correct, but you have to go for the most appropriate next step. So it's the point is most appropriate next step. Um, for first time seers, we will also go for CT scan or MRI to detect for any tumor, stroke, or mesial temporal sclerosis. It just mean there is some fibrosis of the temporal lobe, medial temporal lobe of the brain. So it's due to that. Now, elective MRI is the modality of the choice. In non-emergency or elective situations, MRI is the modality. That's another point to consider. Here is another scenario in which a 33-year-old man. I will prefer you. I will suggest to you to look for the patient demographic and then look for his other examination. Starts from examination. Like in this 23-year-old man, everything was normal. CB system electric ECG are normal. Urine toxicology screen is ordered. So management. Next step in the management. Seer. The patient fell on the sidewalk, so it's a first time seer. The lethargic, confused, so it's a post-ictal confusion, but follows simple command. Mm, Now you have chosen infusion, sanitoin infusion. So before investigation or before uh, confirming the diagnosis, we will not go for it's a treatment. First, we have to investigate the underlying causes, and we will go for it's not status epilepticus. That's why it's not IV phenytoin infusion. Lumbar puncture is uh, mm, uh, for meningitis or encephalitis, and there is no knuckle rigidity or no fever. So we will go for CT scan of the head without contrast, and CT scan of the in the case of brain we will not go for CT with contrast, but always we will go for CT scan without contrast. So that's the correct answer. And also in emergency situations, we will go for CT to rule out intracranial bleed. Uh, okay, so here is the answer of why it's not routine EEG. Routine EEG is useful for risk stratifying patients after a first-time seizure once metabolic and toxic etiologies have been excluded. So it's like some go-to points. Like you starts with most rapid and common things, then go for other investigations, most specific investigations. First, we have to rule out metabolic or toxic causes. So here's the indication to start anti-epileptic medication. So this is the criteria to start anti-epileptic medications, and you need to remember or cram this small table. Like if patient underwent nocturnal CN, then you should start prescribing the epileptics. Or patient have some focal neurologic examination, or patient is showing abnormal EEG or neuroimaging. So here is another scenario in which the patient, 60-year-old man, comes to emergency department with witness seizure 30 minutes ago. So sudden stiffness and jerky movements. So it's a generalized tonic-clonic seizure lasting about 2 minutes. The patient with renal cell carcinoma of the right kidney. So it's a question we were discussing on Messenger. We will obtain MRI of the brain. So here is the key point. Why it's not sodium, because for sodium to become the cause of seizure, should be less than 120, because mild sodium level doesn't cause seizures. So that's why it's not the right answer. And due to the patient age and his history of renal cell carcinoma, we will suspect strongly for renal cell carcinoma metastasis, and therefore we'll do for MRI of the brain. Hypoglycemia, seizure due to hypoglycemia are unlikely with a glucose level greater than 55. Hyponatremia not occur with sodium levels less than 120. So that's a clue, or that's a hint that the examiner is asking about malignancy mets and its management. So we classify seizures according to their onset. If it's originating in one part of the brain or in one cerebral hemisphere, we classify it as a focal seizures. Or if it is occurring, or if it is starting originating from both cerebral hemisphere, we call it as generalized hemisphere. There are many uh, specific causes there are many specific types of focal seizures. So focal seizure is a seizure originating from a single hemisphere. Symptoms can be motor, okay, sensory, and or autonomic. Autonomic means sweating or some other urination, incontinence, or any type of symptoms which are due to autonomic systems. So for motor, patient will present with twitching or some jerky movements. For sensory, patient will experience numbness, pain, something like that, along these lines. So in focus here, that's the important table you need to remember. In focus here, so neuronal discharge begins in one cerebral hemisphere. Symptoms may be motor, sensory, or autonomic. Underlying structural mobility more likely than with a generalized seizure. So, whenever patient presented with focal seizure, we will need to focus on the underlying structural abnormality. So uh, uh, we classify focal seizures into two types based upon awareness. If the patient's awareness is intact, we call it focal seizures with intact awareness. If the patient awareness is impaired, we call it as focal seizure with impaired awareness. So occurrence seizures remain localized to one hemisphere. So it's further clarification of a focal seizure with intact awareness. In focal seizure with impaired awareness occurs when seizure suppress to other side of the hemisphere. Therefore, the patient will experience impaired awareness. To diagnose focal seizures, we will need to do brain MRI and EEG. Brain MRI due to detect a structural lesion like tumor. It can be okay. So simple partial seizures is also called focal seizure with impaired awareness. So that's an old name of focal seizure with intact awareness. So in autonomic symptoms, patient will that's a very classic sensation patient will experience sometimes like epigastric rising sensation, and it's a common with the medial temporal lobe epilepsy. That's an important point to remember. The patient will experience pupillary changes, pyeloid action, or sweating. In psychic symptoms, patient will experience feelings of familiarity, deja vu feeling, or dysphagia, or distortion of time. Patient will experience fear or hallucination. Okay, focus here with impaired awareness, previously also called complex partial. Also spread to focal seizures can also spread to involve both cerebral hemisphere and cause impaired awareness. So, focal aura abdominal aura is a focal reversible focal neurologic dysfunction which will happen in seizures. It can happen with focal seizures as well as in complex seizures or generalized seizures. And here is here is a further classification of aura. Like abdominal auras are more common than visual, and visual are more common than sensory. And for abdominal, the patient will experience usually rising epigastric sensation. Unpleasant and sensory, the patient will experience unpleasant olfactory hallucination. And for automatism, these are common symptoms like patient will experience repetitive semi-purposeful movements, lip smacking, or patient will bite his tongue, or patient will chew something, or picking uncontrollable laugh. Post-ticular confusion and anterograde amnesia. Patient will not remember any details of the event. So, uh, post-ictal confusion, sometimes patient will experience some focal weakness or paralysis. That's called Todd's paralysis. It's a specific in seizures in post-seizure states. Every patient will have some transient. It's a self-limited focal weakness or paralysis. Post-ictal period after a focal onset seizure, which may become secondarily generalized. The pathophysiology likely involves neuronal exhaustion. Symptoms examination reveals a flaccid weakness or paralysis of one or both extremities on the same side of the body. In physical examination, you will see flaccid weakness. The patient will have decreased motor tone and will experience paralysis of one or both extremities on the same side of the body. However, other causes of paralysis, embolism, intracranial bleed should be excluded by CT scan or MRI. Okay, treatment of throat paralysis is spotty because the symptoms usually resolve within 36 hours. Okay, a 6-year-old boy. In this question, the patient demographic is a 6-year-old boy due to difficulty moving his right arm or leg. So it's a like paralysis of arm and leg, fall and then found him responsive to the floor. He regained consciousness after 3 minutes, but he was confused and unable to move his right arm or leg. So it's a like generalized tonic-clonic seizures, and then after seizure patient was confused. So it's a like post-ictal confusion. And in post-ictal confusion, patient was unable to move his right arm or leg. So it's a classic case of thought paralysis. The mother has a history of migraine and is maternal died from hemorrhagic stroke. Note important: the right upper and lower extremities are flaccid. And right sided strength is 0.5, sorry, 0 by 5. So it's a flaccid paralysis in which there is a decreased tone of the extremities, and strength is also decreased. Left sided is normal. CT scan of the head and MRI of the brain are normal. So this patient transient hemiplegia following an episode of loss of consciousness with gradual return to baseline normal imagery is most consistent with thought paralysis.